Our today's topic of discussion is diagnosis and management of myopia. Children with physiologic myopia commonly present with complaints of blurred distance vision. Parents may also notice their child squint their eyes while viewing distance objects. If the degree of myopia is moderate or high, then children may be observed sitting closer to the television and computer or holding reading material closer. Pathologic changes related to high myopia are discussed in the pathology section. The most common symptom of myopia is decreased distance vision. Patients with pathologic myopia may also report visual distortion secondary to retinal pathology. Myopia can be detected in children by various vision screening procedures at the pediatrician's office or at school. A significant refractive error is suspected when visual acuity is reduced during a routine eye exam or vision screening. Although vision screening techniques such as photo screening and auto-refraction can detect myopia, the prescription can only be accurately quantified using manifest or cycloplegic refraction. See clinical diagnosis. Myopia is most accurately quantified using manifest or cycloplegic refraction. Cycloplegic refraction is the gold standard for diagnosing any refractive error in a child. Children generally over-accommodate during manifest and auto-refractions, causing their refractive error to appear more myopic. Cycloplegic refraction is therefore necessary to determine the most accurate prescription and to avoid over-minusing children. The pathology that can be associated with pathologic high myopia is diagnosed with a dilated fundus exam. Management. The standard treatment for myopia in children is glasses. A concave lens is used to diverge the light rays entering the eye and place the focal point on the retina. Once children have matured enough to handle the responsibility, then contact lenses may be an option. Most ophthalmologists agree that patients should be in their pre-teen or early teenage years before considering contact lenses, however the decision is made for each patient based on their level of maturity. In special circumstances, refractive surgery may be indicated for children with neurological impairment, neurobehavioral issues, facial deformities, craniofacial, hemifacial microsomia, ear deformity, or severe anisometropia that render it impossible for glasses wear. Although contact lenses are usually the secondary treatment option for children with developmental anomalies, there are concerns for infection, mishandling, and expense. Refractive surgery for the general population is usually only indicated once the patient has stopped growing, which generally occurs in the late teens to early 20s. Keratofractive surgery uses lasers to reshape the cornea and attempts to produce an emmetropic eye. If the surgery is successful, then the patient will have excellent visual acuity without glasses or contact lenses. Photorefractive keratectomy (PRK), laser in situ kertomileusis (LASIK), and laser epithelial kertomileusis are the most commonly performed refractive surgeries. Intraocular refractive surgeries are becoming more commonplace. Various therapeutic modalities have been implemented for the treatment of myopic progression. The efficacy and safety of several of these treatment methods have not yet been determined. Currently, there are no general guidelines for preventing myopia, and the use of non-medically proven treatments remains controversial. Studies have shown that intensive near work may be a contributing factor for myopia and myopic progression. Many authors have speculated that accommodating during near work may be contributing to the progression and development of myopia. Both refractive and pharmacological methods of eliminating accommodative demands while participating in near work have been investigated. Many studies have investigated the effect of decreasing accommodation in myopic patients using single vision, bifocal and multifocal lenses. In 2003, the Correction of Myopia Evaluation Trial (COMET) studied the effects of progressive additional lenses (PVLs) and single vision lenses (SVLs) in 469 myopic children. Their preliminary data showed a slowing of myopic progression by a statistically small amount during the first year of PVLs when compared to SVLs. The authors concluded that it did not warrant a change in clinical practice. There is significant debate over the efficacy and long-term outcome of bifocals for the prevention of myopic progression. A recent study in 2010 by Cheng et al. Studied the effects of bifocals and prismatic bifocal spectacles on myopic progression in Chinese-Canadian children. The authors showed a greater reduction of myopic progression and axial elongation at 2 years for children in bifocals and prismatic bifocals as compared to the SVLs group. Unfortunately, the study did not provide long-term follow-up data. Accommodation can be inhibited by using an eye drop that contains a muscarinic receptor antagonist. Atropine and pirenzepine have been the focus of studies investigating pharmacologic prevention of myopic progression. A study in 2016 by Chia et al. Compared 0.5%, 0.1%, and 0.01% atropine for prevention of myopia progression, finding that although at the 2-year mark there was a dose-dependent reduction in myopia progression, high concentration meant greater reduction in myopia progression. During a 1-year washout period, there was a larger rebound effect associated with higher concentrations of atropine. Essentially, over 5 years, the 0.01% atropine group was found to be most effective in slowing myopia progression and axial elongation with less visual side effects compared with higher doses of atropine. A report by the American Academy of Ophthalmology in 2017 concluded that there is level 1 evidence that supports the use of atropine to prevent myopia progression, and that given the more sustained effect and fewer adverse effects of 0.01% atropine, it may the most reasonable approach, though the optimal time to initiate and discontinue therapy is not known. Ultimately, clinicians, patients, and families must decide whether the effects of atropine 0.01% are clinically significant enough to warrant its use. Pirenzepine is another muscarinic receptor antagonist, and unlike atropine it is relatively selective for the M1 receptor and less likely to cause cycloplegia and mydriasis. 2 similar studies invested the efficacy of pirenzepine using multi-center, double-masked, placebo-controlled treatment trials. A 50% reduction in myopic progression was shown in patients that used 2% pirenzepine gel in 2005 by Tan et al., and again in 2008 by Siatkowski et al. Both studies showed an excellent safety profile with significantly less side effects than seen with atropine. Currently there are no long-term follow-up data on pirenzepine. A highly controversial treatment modality for retarding myopic progression is the use of overnight rigid contact lenses, orthokeratology. These lenses temporarily change the refractive state of the eye by applying pressure to the cornea, creating a non-physiological shape. There are currently no large studies that have shown a benefit to overnight rigid contact lenses. There are several studies that suggest temporary benefits of orthokeratology, however due to small sample size and no long-term follow-up data, these studies remain inconclusive. In 2003 Katz et al. Performed a large randomized trial of 298 Singaporean children that showed that myopic progression was not reduced with overnight contact lens wear, and the authors concluded that there is no apparent benefit to orthokeratology for the treatment of myopic progression. There are potential sight-threatening and devastating risks associated with overnight contact lens wear, and numerous reports of corneal infection and scarring have been published. The positive effect of outdoor activity for reducing myopic progression has been documented in numerous studies. Physical activity, sports, and low accommodative demands have been postulated as the cause of this protective effect. The Sydney Myopia study in 2008 demonstrated a significant reduction in the prevalence of myopia in children who spent more time outdoors. After adjusting for time spent on near work, parental refractive error and ethnicity, they showed that increased time spent outdoors, rather than physical activity, was associated with less myopia. The authors of the article suggest that light intensity when outdoors may be the contributing factor, by increasing depth of field and decreasing image blur. They also comment on the possible effects of light on the release of dopamine from the retina, which is an eye growth inhibitor. In 2015, Reed et al. Used a wrist-worn light sensor to objectively measure mean daily ambient light exposure and found that children who experienced low average daily ambient light exposure exhibited significantly greater eye growth than children experiencing moderate or high levels of exposure. A study from Taiwan published in 2018, explored the merits of a school-based intervention aimed at increasing outdoor activities and sunlight exposure, and found that this sort of intervention can be effective in slowing the progression of myopia. The study also found that shorter outdoor time with high bright light exposure was roughly equivalent to longer outdoor time in moderate intensity light in slowing myopia progression. Patients with early onset and high myopia have a worse prognosis for long-term visual acuity. These patients tend to have a higher rate of myopic progression with longer axial lengths. Patients with longer axial lengths are at a greater risk for developing myopic retinal degeneration and other associated pathology.